of diagnostic testing in innovating patient pathways. I'm Danielle Jeffries, a senior analyst at the King's Fund, and I'm going to be chairing this event today. I'd like to start by thanking our event sponsor. This event is being sponsored and funded by Roche Diagnostics UK and Ireland. Today, we will be focusing on in vitro diagnostics, which are tests that can detect disease, conditions, and infections done on samples taken from the human body, such as blood or tissue. They allow doctors to diagnose patients effectively and work to provide appropriate treatments. We have a great panel of speakers today, and I'll now introduce them shortly, and they represent a whole range of perspectives. But first, I'll briefly introduce this session and how it will work. So this event is live and will include a panel discussion and a live Q&A. So you can submit your questions in the Slido box, which should be in the right-hand side of this panel. And we'll aim to answer as many of the most popular questions as possible. So you can also upvote questions there too. We will also be putting some poll questions to the audience, and these will flash up at various points during the session to the right-hand side. So please do take part in them. We also encourage you to follow the conversation online using the hashtag KFOnline for Twitter. And we recommend you look at the resource page, which you can navigate to on the left-hand side menu as well. Finally, we have a really great audience for this event. We just checked before coming live, and we have over 2,000 people registered already. And we have a really broad audience watching today from across different sectors and organisations. So knowing this, we'll endeavour to keep the conversation broad, and we'll explore some certain themes within this conversation. So things like the potential of increased access to diagnostics, what innovations in patient pathways mean for those working in the system, and the role of integrated care systems and how they can play a part in developing in vitro diagnostic services. So I'd now like to invite our panel to briefly introduce themselves. Unfortunately, Amy can't join us today, but we do still have a great panel. So I'd like to introduce them now. So Jane, if we could start with you.
Thanks, Danielle. And first of all, just like to wish any biomedical scientist colleagues on the call a happy IBMS day. That's a little bit of a personal reach out to them. So hello everybody, my name is Jane Mills and I'm Head of Pathology Transformation for NHS England. What that means in my current role is I'm leading on the agenda to form pathology networks, obviously responsible for making sure I understand what NHS pathology services need to continue to evolve and develop their services and help secure resources from government to help support them. We're also taking a look at histopathology transformation in a little bit more detail, and very much in line to this particular event is as a programme we're starting to lean in more and more to in vitro diagnostic point of care testing. So delighted to be here today on the panel.
Great, nice to have you, Jane. Mona.
Hi, I'm Mona Sidhu. I'm a GP for about 24 odd years and a medical director for primary care at the Black Country ICB. For those who don't know Black Country is next to Birmingham, has got Wolverhampton, Walsall, Sandwell and Dudley. We look after a circa of 1.26 million population, got 4 trusts, 181 GP practices and 67 PCNs, and I'm really interested in vitro testing and looking at how this can help our population and our GPs and community services provide better and faster care for our patients. I'll stop here.
Thanks, Mona. And Mandy.
Hello everyone, I'm Mandy Townsend and I am a biomedical scientist, so it is Biomedical Science Day today, so thanks Jane for the shout out. I'm also Associate Director at the Innovation Agency and I lead the Pathway Transformation and Complex Change team there, and the Innovation Agency is the academic health science network for the North West Coast. So we're one of 15 across England and we also work closely with colleagues in Wales and Scotland. So our role is to help the NHS innovate and adopt and spread proven innovations as quickly as possible.
Thanks, Mandy. And Ashton.
Thanks, Danielle. So I'm Ashton Harper. I'm Head of Medical Affairs for Roche Diagnostics for the UK and Ireland. I lead a team responsible for late-stage clinical research across our entire portfolio, which includes research into oncology, cardiology, infectious diseases, women's health and neurology. And so, yeah, we're responsible for clinical research in the UK and Ireland. I've worked in medical affairs and industry for the past 8 years, largely designing clinical research. And before that, I worked in the NHS as a doctor and trained as a gastrointestinal surgeon.
Thanks, Ashton. So let's get into the discussion today. So diagnostics have always been an essential part of the patient pathway. However, in the last few years, the value of having diagnostic capacity, particularly in vitro diagnostics in primary care and community, has become more and more evident. Innovation is allowing care to be delivered in different settings, including closer to the patient's home and also virtually, and it can allow different staff to deliver care while also saving clinician time. All of which is great in the current health and care system, particularly in the current context of staff shortages. And rapid early diagnosis of patients in the community can help keep patients out of hospital, which are already struggling with capacity. And potentially, most importantly, it benefits patients. Having diagnostics closer to the home can help people live healthy lives at home and in the community. So over to our panel now. I have a few starter questions for each person. So I'd like to start with a question for Jane. So Jane, we have a lot of existing experience in the system, particularly in pathology networks. How do we ensure this expertise and knowledge of what works is being utilised by those designing services?
Yeah, great question. And actually it's quite timely because we're just currently encouraging our pathology networks, of which there are 27 now across England, to take a look at themselves using what we're terming a maturity matrix. And one of the domains that we ask them to look at is their operating model around their point of care testing service. So we're learning a lot about what that expertise is out in the field at the moment. And what we see is those pathology networks are likely to be a great source of resource and expertise that our commissioners and designers of health systems can draw upon to help guide them on choice of equipment, to help understand the accreditation landscape and how we keep our patients safe with the use of the types of equipment that our point of care testing services are familiar with. As a programme board, we recently asked the professional bodies active in this space, so the Royal College of Pathology, Association of Chemical Scientists and the Institute of Biomedical Science, to give us some guidance on point of care testing, and they've recently published a paper which is really, really helpful and gives us some clear recommendations about what they think would be beneficial for us to focus on as we develop point of care testing services. So and I think it also helpfully illustrates that we see point of care testing in a variety of settings, self-testing, home testing, clinical environments, as well as hospital. And somehow we've got to work out how do we keep patients safe through all of that role. And as I say, our pathology networks carry some experts now who are continuing to develop their level of expertise in this field, who are well placed to guide on best use of it. I suppose one of the other dimensions that it would be right to bring in is the reflection on the digital landscape that we have. And as part of our pathology network maturity programme, we've got significant investment supporting digital roadmaps that our systems have laid out for themselves. And as we introduce more and more point of care testing, clearly it would be hugely beneficial to make sure that the outcomes from those point of care testing diagnostics are incorporated into electronic patient records or the single patient record. And that's new territory for us, to be frank. So there's going to be a lot of work, I think, over the coming years to understand how do we codify what comes out of point of care testing, how might that work in our existing digital infrastructure, and what else do we need to add to the digital infrastructure to make sure that those results are finding their way into patient records. And I think one last comment I would make is pathology doesn't work in isolation. We work across and work collaboratively with so many different professional skills to deliver our services. Procurement and commercial expertise, clinical engineering examples, and obviously our nursing community and those users who guide patients on the devices. So I think it's going to be really important for integrated care systems to really help bring those groups together and work out what a new clinical governance model might look like to ensure that a system delivers safe point of care testing. Thanks, Danielle.
Thanks, Jane, and really great points. And I'm sure we'll pick up on the role of integrated care systems more later. But now a question for Mona. So how is this playing out in the Black Country Integrated Care Board? How is your ICB engaging with pathology to transform patient pathways? And what more can be done to make sure that services are designed with people and the communities at their heart?
Sure. Thank you. I see. Thank you for the great question again. I think the main points to cover in your question are twofold. One is how do we engage with the Black Country Pathology Services, and how do we ensure that whatever we do doesn't exacerbate health inequalities, in fact helps reduce health inequalities and inequities in care. I think the Black Country ICB works really collaboratively with the collaborative partnership with our Black Country Pathology Services. And it's very useful when we're designing any improvements to patient pathways. We work with our colleagues to understand what are the key challenges in the pathway, and electives and diagnostics being one of the main challenges, because we need to ensure that that is at center of improving the patient pathway. And co-designing a whole pathway with them on board would be really key for us. And that, with that in mind, we have got provider collaborative, which has got acute collaborative colleagues working across, and we've got a primary care collaborative where we've got primary care, because at the end of the day, we've got implementation at various levels, which needs to work across the system, across primary, secondary, and community care. So I think we've got great working relationship, and I suspect most ICSs would as well. In terms of your second part of the question around the health inequalities that could be exacerbated by this, I think if we design the systems and the processes, we should be able to use these in order to mitigate those health inequalities by bringing point of care testing closer to home for some people. And just giving you some examples, and like Jane said, point of care testing is nothing new. Point of care testing has been done by patients themselves in terms of pregnancy testing, urine testing, blood sugar testing, and INR testing. And again, that if they do their own INR testing, it saves time and so forth. So and making sure that across the system, where possible, we're encouraging those self-testing by patients. Then we also have point of care testing, which are set in hospitals, which saves time. So for example, pre-op checks for blood counts, UNDs in diagnostic centers where they have radiology, and in STECs, we have D-dimers and so forth. There is with the emerging evidence since the pandemic that we need to provide these, and there's a huge issues and delays in pathology services following the pandemic. We wanted to make sure that we look at how we innovate and provide these tests closer to home for people. And there are two areas where I feel that they are really, really useful. They would be more useful in a center like a PCNs come together in a hub based, where you can see patients and the volume of patients, and you have consistency of use and experience. In our Black Country, we have some areas where they do D-dimers by themselves. So patients who have got, say, a swollen leg, this point of care testing for D-dimer, we can exclude a DVT, saving transport to the hospital. And that, again, is a saving for the whole pathway and leads to better patient outcomes and experience. In addition to that, we have also got a community team. So working really, my colleague Simon Harlin at Walsall mentioned that there are some community teams who go out to patients, especially monitoring people who have got who are in chemotherapy and spike a temperature, checking their full blood count, making sure there's no neutropenia as such. That helps them manage the patient without actually getting the patient into hospital. There are other areas which are being explored in our Black Country PCN. We've got RSV hubs, where we use patients who've got we could be using point of care testing for patients with suspected illnesses and ensuring that we don't prescribe antibiotics inappropriately and triage them. So there's CRP testing, there's RSV, lots of respiratory virus testing as well. So I think those are a few. It's very early days for us, and I think we welcome people like Jane and Pathology Services coming and telling us about the innovation and what's on the horizon, and telling us about what can be used. And I was having a discussion with my colleague earlier on. We were thinking about doing BNP testing for COPD care as well. Again, these patients present with shortness of breath, and rather than transporting them to hospital or having a delayed diagnosis, that could be another thing that we can explore. I think we should be mindful that this is going to improve patient pathways, but also is going to take a clinician time and resource, and how it, like Jane mentioned, about linking to making sure the processes are smooth and linking into patient records and so forth. So we need to ensure that there's cost effectiveness analysis done and resources for primary and community cares assessed, along with adaptation and implementation of primary POC testing in primary care and community care. I'll stop here.
Thanks, Mona. Some really great examples there. And as we're talking about innovation, Mandy, I know you're working on an interesting flu test and treat pilot. So what are the opportunities and barriers you've noticed in that project? And are there any potentials for scaling up the approach?
So can I tell you a little bit about what we've done? So we started with one PCN, and we co-designed the pathway with them, rather than trying to impose it. It was actually designed by the primary care team, and that was quite an interesting experience, I think. Applying some of those lean and improvement techniques that are used across secondary care quite consistently now in a primary care setting was quite, I think it was really interesting for them. But it also made it clear that actually there's probably quite a lot more that could be done in that space as well. I think the other thing that we have done is we started the project 2 years ago, but the winter before last, there wasn't really a flu season, so we didn't actually launch the pilot until this winter. So what we had time to do was to make sure that other PCNs could be involved. So we've also involved 2 PCNs in Yorkshire and Humber region, and we tweaked the pathways to suit the workforce and the availability of people within those primary care networks. And we actually did place some devices for testing in the primary care hubs in those primary care networks. So rather than spreading it across, we actually placed them in the primary care hubs. We made sure that the results were available and were written straight into the GP record, and we're fortunate in the north of England in that we have shared care records, so those results would also be available if the patient was subsequently admitted to an emergency department, removing the necessity to test twice. I think that's something that's important as well when we think about when we're doing point of care for infections or diseases in the community. If the patient is subsequently admitted, it's not a good use of resources to do the test twice. And that also enabled the governance around notifying the public health departments, because both flu is a notifiable disease, and it also made it permanent in the patient's primary record, which is in the GP system. So we undertook the testing, the pilot proof of concept testing over the winter this year, and we tested 250 patients. We also involved patients by asking them in advance what they thought about the existing flu pathways, which were very diverse and really quite complex. And we've also asked them afterwards. So 30% of the patients who went through the testing actually responded and gave us their views on how it went for them. And we've run a real world evaluation alongside it using an independent health economy company, which is currently analysing the results. So it was interesting in terms of that. So we will have, and we're also developing a business impact model. So we'll be able to impact the tests, what the cost of those are across the health economy, but that's not quite ready for publication yet. So we've been asked to think about what are the barriers. I think the barriers are that each system is currently was in flux at the time. The ICBs had only just been formed. The governance and the approvals procedures were different between the different ICBs. So we had another academic health science network area that wasn't able to join because their ICB hadn't decided what the approvals processes for that kind of project would be yet. The other barriers that I think were around how we manage that and how we link that with pathology governance, because I think it's all very well doing it as a proof of concept, but actually if we're going to put devices or tests into primary and community settings, it needs to be linked in with the pathology point of care governance frameworks. There's only one thing worse than not knowing the result, and that is actually getting the wrong result, and without that appropriate governance you are at risk of that. And I don't think that currently the pathology departments are necessarily resourced and ready for that. And I'm really pleased about the work that Jane and her team are doing that will help them get into that position. I think the other thing is that actually it's probably a small pilot at this stage. We only tested 250 patients. So I think the next stage for us is to work with our ICBs and probably with Yorkshire and Humber to try and scale it to ICB level, and to actually make sure that pick out that it is scalable, because there are different workforce models and the workforce impact is really important. So I think all of the feedback from the professionals is very positive, but we need to make sure that it's potentially there, that it's not going to make the workload higher, that it actually enables primary care to use their skill mix that they've got with the R's roles to support this kind of thing. And then probably I think the other thing that we need to do in terms of scale is to make sure that it's aligned with the other work that's going on with the UK HSA, and Oxford Nuffield are doing tests around lateral flow devices in point of care, and actually working out what is the most effective and cost-effective way of doing it, because it may be that we have different use cases for different settings. So it may be more appropriate in an acute respiratory hub to have a wider panel than a lateral flow test can give you, because it will give those prescribing clinicians better diagnostic certainty, but it may not be cost effective. We need to test that, I think, before we go to a national adoption and spread for that acute respiratory illness type point of care testing. Does that help? I think the health economics and the business case and the business impact modelling are really vital to enable us to feed this into the national innovation pipeline, and it is on that pipeline, and colleagues are watching across both NHS England, UK HSA and the AHSNs to see whether or not this is successful and where we should go next. Does that cover your questions, Amy?
Yes, thanks, Mandy. Yeah. So thanks for sharing those reflections and learnings. I'm sure it will be really helpful for everyone listening. So building on Mandy's theme of learning from patients and the workforce, Ashton, I've got a question for you. So what do innovations in patient pathways mean for patients and those working across the system? And how can we support the workforce to realise the potential benefits?
Yeah, thanks, Danielle. So we know that diagnostics, or the majority of clinical decisions rely heavily upon diagnostic technologies, and without many diagnostic technologies in common use today, the delivery of modern healthcare simply would be impossible. We'd really be in the dark ages. But there's always room for improvement, and really this is where sort of innovation in pathways comes in. And the aim essentially is to improve efficiency or the effectiveness of those pathways. And that might either be through introducing a new technology or utilizing what we already have, but in a better or different way. And so benefits for patients really should be primarily focused on improving outcomes and safety, but also improving access to diagnostics and actually satisfaction with the service that they're requiring. So either that they're having, so either through reducing waiting times or reducing frequency of appointments. And then benefits for those delivering healthcare and the wider healthcare system. So we know about NHS shortages and increased backlogs at the moment that are causing huge pressures. So improving approaches to pathways to help with this pressure by enabling more efficient use of staff time and resources to reduce healthcare expenditure. So we often also hear about situations where testing is not being utilized in one part of the system, say with GPs, because the cost saving and improved patient outcomes might be actually delivered or realized in other settings, such as in the hospital. And we're really hoping that with the integrated care systems, that this is going to offer a good opportunity to overcome some of these issues. So we've just heard from Mandy, obviously, about this innovative approach to test and treat community-based influenza pathway. And another area that we're working quite heavily in is heart failure. And so we've been doing a lot of work with charities to raise awareness and identify the unmet need in these pathways. So just as a bit of background, so heart failure, much like cancer, can be divided into 4 different categories of severity, ranging from 1 being mildest to 4 being the most severe. And actually life expectancy, if you're identified in stage 4, is half that of being identified in stage 1. But unfortunately, in the UK, the majority of patients are actually diagnosed in these later stages. And we also know that approximately 80% of patients are being diagnosed in hospital rather than in the community, despite many of those patients actually having early warning signs that might warrant earlier testing. So, in a recent survey that we worked with a patient charity in the UK, identified that actually less than a third of patients are receiving a simple blood test that's recommended by NICE to identify heart failure. So what we're looking at doing is raising awareness and hoping that in primary care, adoption and following NICE guidance is more routinely done, because we're definitely seeing variability across the country. And another promising area that we're working in, again with heart failure, is looking at remote patient monitoring. So what we can do is, after a patient's been diagnosed with heart failure, we want to try to avoid costly and damaging readmissions for patients. So by enabling patients from the comfort of their own home to take regular measurements like blood pressure, weight, heart rate, and their symptoms, they can input this information into an app, and that is centrally analyzed by cardiology specialist nurses, and they can offer management alterations for that patient to prevent readmission to hospital. So we're seeing really good patient feedback from that process, and hopefully that's going to improve outcomes in the long term. Mona also mentioned about point of care solutions, and I think there's a number of different technologies that can be utilized in the community. So mentioning about D-dimers for deep vein thrombosis, but also for testing for common respiratory conditions in children, such as strep A throat, or respiratory syncytial virus, and also for testing for flu and COVID. And if we can do these things in the community, we can hopefully reduce prescriptions for antibiotics, which will help to reduce the impact of antimicrobial resistance. And will also hopefully prevent patients presenting to hospitals when they are infected, that might cause outbreaks in hospitals and cause further negative outcomes for other patients. So I think there's a number of opportunities that we can engage with with point of care testing to help to improve patient outcomes.
Thanks, Ashton. So I've now got a couple of slightly broader questions for the panel. So my first question is, how do we improve the adoption of innovative testing? How do we support clinician training, education, and design systems that work for both clinicians and patients? So would anyone like to come in on this question?
Can I start? Is that okay? So I would say that actually adoption of innovative testing, it sounds like it should be really easy, but it isn't, because I think it's not just around the governance and some of the things that I talked about before, but it's also around what are the funding mechanisms, who's going to pay for it. It takes time. Somebody has to do the test, and they have to be trained. They have to know how to do it. And I think I'll leave that to more experts to talk about that, and how we skill mix that as well is a question. But I think it's, if we're going to do it, a lot of AHSNs have supported pilots for another test which looks at whether or not a patient has bacterial or a viral infection, and when that generally hasn't so there've been lots and lots of pilots, but actually because of the cost of the test and there's no reimbursement mechanism, most of those in primary care have not continued or gone on to become an embedded service. So I think there's something around how we think about that, the funding mechanisms and the work that we do. And then there's about, actually, it's about co-designing it with the people who are going to deliver the service, because they don't want things to be imposed on them. A lot of GP practices work in very different ways, depending on their staffing mix, the environment that they've got in terms of buildings and equipment, and in terms of the demographics and the population that they serve. So things will, one size doesn't fit all in this setting, I think, is my conclusion from that. And I'll hand over to someone else.
Well, I could just pick up on the reimbursement element, Mandy. I mean, unlike medicines, when diagnostics have a positive, nice recommendation, they don't automatically have mandated funding. And also we know that the funding for adoption is far less than that spent on R&D. I think it's about 4% of the total NHS budget that's comparatively spent on research and development. So clearly a lot of work has to go into that to change things. And just thinking about it, it often takes more than 10 years at the moment for the adoption of a new diagnostic. I mean, take for example, we have a test for preeclampsia, which is a condition that affects pregnant mothers, about 1 in 25 pregnancies, and this is a condition that could have really serious outcomes for both mother and child. The problem with this is that we've got a test that's able to accurately rule out this condition and prevent mothers, expecting mothers having the stress and hassle of having to be admitted and the cost imposed on that. But we had regulatory approval for this test, I think back in 2009. We then had a positive NICE approval or recommendation in 2016, but it took a further 5 years for that to be routinely adopted at scale. And that was really down to engagement with Academic Health Science Network in Oxford, and also the Accelerated Access Collaborative and this new route to mandated funding. But it just shows how long I guess a success story, but it just shows how long that has taken when everything it fits into place. And I was just going to say as well that COVID as well gave us a good example. I know it's sort of an unprecedented situation, but when we all worked together and pulled out all the stops, we were able to bring out a test within weeks. And so I'm not saying that we're going to do that for every condition, but there needs to be some sort of middle ground between COVID and this decade that it takes. So yeah, I'm hoping we can address that in the future.
So I'd say actually that a decade for PLGF is a success, because the average time it takes for the NHS to adopt a clinically proven innovation is 17 years without the involvement of without some kind of support and push across the system. So I think that is interesting. Yeah.
I just offer a few reflections on that, and I think the lessons learned through the pandemic and the rate of adoption is a really powerful one. I think I'd also combine that with the Getting It Right First Time initiatives, and particularly looking in pathology. We've now got some great support from the Getting It Right First Time team to look specifically at this rate of adoption of NICE approved technology. And through the combination of the pathology quality assurance dashboard, where we can get visibility of adoption of approved technologies, we're hoping to be able to just bring more to everybody's awareness of, first of all, what are the NICE approved technologies that could be deployed, and then also illustrate how they are being deployed. But I think it's almost a call to action to system leaders to be curious enough to want to prioritize this for themselves. That best use of diagnostics is really powerful in this recovery space. And we are into a new environment with integrated care systems where that whole balance of opportunity for system leaders is now changing and can be, I hope, quite powerful through that local determination, which Mandy, I think you were evidencing, in where it works well is when there is that traction locally. So, you know, I think for us as NHS England in this space, we'll want to just keep making it possible to share knowledge quickly, to try and make sure we've got some of those system architecture environments to support adoption, and encourage and monitor adoption. And I think underpinning it all, and a number of people have said it, is there's definitely something in the funding mechanism that we need to take a look at over the next few years to say, is there a better way of helping to prioritise the funding on this?
Thanks, Jane. And Mona, did you want to come in on this question, please?
I did, because I think it's just about implementation in primary care, and it'll be very amiss of me if I didn't come in on this. I think it's having that technology and being aware, as Mandy and Jane have said, is really, really important to know that it is out there. But I think in terms of, as Mandy said, it's about co-designing and understanding how it's going to be implemented, making sure that the whole pathway is seamless and talks, the IT system, the digital systems talk to each other, so there's no duplicate entry, there's no duplicate testing as such. And in order to do that, I think Mandy's already checked on, addressed that already, about the workforce and workload issues. So taking an example of, say, if we put a CRP machine or a flu testing machine in each GP practice, there needs to be a whole process that needs to be thought through. Where is it going to be placed? Who's going to do the testing? What's the training? What's the number of testing tests that they would run? And how quickly are the results available? And does the practice have capacity to do that? And most of the times, because it's already been alluded by my colleagues, that practices are quite varied in their makeup in terms of number of staff, size, population they serve, and so forth. So I think if we want to make sure that this has got tracked from a system level, we need to understand where it would be best used. What is the most cost-effective option for this to be used? And it may have, like in Sandwell, we've got an RSV hub, which was created over the winter period, looking at children who were presenting with symptoms of respiratory syncytial virus, and checking that and saying, is that RSV? Is it something else? Does it need treating? And so forth. And similarly, if we have a general consensus around acute hubs for PCNs at team levels, neighborhood team levels, or at level of system levels, depending upon whatever the issue that we were testing, that needs to be thought through. And the second thing that I think Mandy alluded to was that we have different measures for different tests. So we have like one machine testing for CRP, another one testing for UNDs, another testing for full blood count. And if you were taking all this to people who are, say, perhaps disadvantaged or had marginalized communities and so forth, and going there, you'd need, and it's not possible at this moment in time, but technology and investment to ensure that we have a wider panel within a single machine as such. So we identify what are the key panels that we would need, how would they would work, co-designing with primary care to see what would you need. So you would need a BNP machine, as Ashton was alluding to, for testing, but you'd also need UNDs. So you would then have to take a sample again later on to just say, are the UNDs okay? Could we have a panel which actually addresses those? We have panels which for doing NHS health checks, which check for cholesterol and HbA1cs. We need UNDs to ensure we are able to prescribe those medications, and it doesn't negate the possibility of taking people to having a separate blood test. So I think just all these things need to be costed out in the whole patient pathway to see where is it most cost effective. And I think from Mandy and Jane's point of view, in terms of appraising those technology, appraising the NICE standards, making sure that we've got all that information for the ICBs to make those robust discussions and decisions to see where the investment needs to flow is really, really key for us. I'll stop here.
Thanks, Mona. And I do have one final question before we move on to Q&A from our audience. And it brings together a few of the things we've been talking about already. So my final question is, how do we recognise the impact of diagnostics when cost savings might not be in pathology? but elsewhere in the system. So for example, keeping people off waiting lists or out of hospital. How do we build the evidence base around its impact and feed it into future decision making? And what's the role of ICBs in this? So would anyone like to come in on this question? We've got a couple of minutes before we move on to our Q&A.
I can get a start, and I think Mandy's already partially answered this question when she explained what they've done with the flu. I think if ICBs are going to make decisions around resources and funding, they would need an evidence-based approach for these utilization of these tests in the community. I think clinically and according to NICE guidelines, they would make sense, but they would need a cost effectiveness and benefits analysis done. And they would need to work with the providers of this system. The providers would need to work with system developers and see how is the data going to be collected in an easy way. So like Mandy mentioned, for the flu, there were like 250 odd patients, and they were thinking about including other ICBs. Research for this would be key. So make sure that we define your key metrics in the first, make sure we collect the data, and then build that evidence base to be able to feed back to the ICBs to make robust decisions. I'll stop here. I'm sure my colleagues may want to come in because I think Jane did mention something about GIRFT as well.
Yeah, thanks, Mona. I think you've exactly said the thoughts that are in my mind about that importance of encouraging the audit and the evidence gathering to support the further understanding of those economic models. And I suppose I'd look back to what I said earlier about how we have a responsibility to make sure we put in place some of those environments to bring together those audits and that evidence base and understanding to help further the deployment of appropriate point of care testing. I think quite often we look for quick answers, and I suspect this isn't going to be a piece of work that can be done quickly. It will need to be over a period of time. But I do think now, with the sort of the spotlight that's being shone on this area, I think there's a really strong likelihood that we will start to make more sense of where we have a choice of doing a test in a lab or a test as a point of care testing, that we build more of a sort of framework that helps answer that question of how do we test the best test environment to use.
So I'll comment on this as well, if that's okay. So I think we talk about real world evaluation, and that isn't research per se. It's more about testing whether or not a new pathway or a new innovation works in the setting that we're putting it in, and whether or not the health economics and the business cases stack up. And I think, you know, we've made a really good start on that with the flu test and treat work. And I think that actually we need to use a similar approach for other tests in point of care as well, because I think it has to, if you know, it's always going to be more expensive, I think, to do point of care than it is to do a test in a laboratory. So it needs to both have a immediate impact on the patient care, so that the doctor or the prescriber can make a decision faster, which might improve that, or it has to have an immediate impact on the patient experience, as in it's really quite difficult for some patients if they're not socioeconomically deprived to get to places where traditional blood tests and hospitals are. It's not cheap, and in the current economic environment, I think we need to think about that as well as the actual impact on the decision making. But I think that's where the health economics and the business cases come in. And that's where I think the rigor of the academic health sciences and the Office for Life Sciences commissions for national adoption and spread and the Advanced Access Collaborative come in. So if those tests and that condition and that pathway is economically viable and does create savings, then that is something that they can help push. But I think if I was in an ICS or an ICB, I would want to know that it was going to save me money or save me beds in the acute hospital, because then, or redivert patients from potentially really long waiting lists. That's somewhere else that would help create the case, I think. And I think it's up to us in the community to develop those business cases and those health economics cases, and to support NICE and the pathology and GERFT to make sure that those things are visible and are present, so that these kinds of tests can be made more widely available.
Thanks, Mandy. Great discussion. I do want to move us on to our audience questions though. So I'm just going to go through some of the top questions we've seen. So our top question is, can the panel talk about their engagement and involvement of experts by experience / lived experience members in developing existing and future services? So would anyone like to come in on that question?
So I can say that for the flu test and treat work, we did involve patients at the very beginning of the pathway design process. We used a focus group methodology, and our PPIE team, our patient and public engagement team, have been embedded throughout the process, both in terms of the design and the testing, and also the analysis of the results. So I think it helped and it adds value. I think particular value was the difference in the diversity of their experience before we put the pathway in place, and the more consistent experience afterwards.
So just to say about the example I gave in heart failure, we started off by conducting surveys, working with patient charities both in the UK and Ireland, to explore, to actually ask patients diagnosed with heart failure what their journey had been, and what the barriers to diagnosis and various issues they had in that diagnostic pathway were. And then we did work to raise awareness about that, and then continued work. We're investing in research and development to improve these pathways and to enable patients to remain at home rather than accessing secondary care. So I think it's really important to have patient input to really know what the unmet need is there.
Thanks both. Yes, really important. And Mona, did you want to come in with this question?
I was just going to say, with regards to your previous questions around health inequalities and so forth. So we've done, just the only thing that we're piloting in that area is the NHS health checks, and we realised that in our area that we had very few people low uptake of NHS health checks, and we realised how important it is for the prevention agenda. So we moved this testing to places of faith, and so that people could access that. So it was more about where the tests could be done rather than them accessing other areas. And also in areas in town centres that we've created a health and well-being hub where people can go in while they're shopping and having those tests done. And we've had great feedback from patients because they felt that they were, their GPs practices had come out to where the communities were, so they'd come out to places of faith to do their NHS health checks and advise them around that. And also in the town centre itself, where there's increased footfall, we could address those feedback and get feedback from patients as well, and just been generally really, really positive because they feel that they could get their test there and then. So it's the speed of diagnosis and the advice that they got, and otherwise addressing those people who would be hard to reach. That's it.
Thanks, Mona. And our next top question is, how can we improve capacity later down the pathway if we enhance early access to diagnostics? Are these two elements being modelled in sync across ICSs? So are we going to see improved capacity if we have early diagnostics? Anyone want to come in on this question?
I mean, I can share some reflections that I've heard over the last few weeks, and obviously we're doing an awful lot as part of the recovery in the NHS to try and increase access to diagnostics through CDCs and other channels, and with particular interest in early diagnosis of cancer and cardiac conditions. I think so far what we're seeing is making it possible to test earlier isn't necessarily reducing any demand. I think we're seeing quite a for downstream testing as well. Actually, we're seeing it all stay high, and that might be an artifact of the fact that there's just a great opportunity to capture early diagnosis, that it isn't actually going to be a step that negates subsequent testing. So I think there's going to be quite a lot of system learning as we now build that ongoing audit to understand, is this just about creating greater opportunity for access? rather than sort of some kind of substitutional diagnostic shift in the patient pathway. And it'll be complex, won't it? It'll be a combination of all of those factors going on, which is why I'm saying we've just got some early indicators that says at the moment, it's just the demand is just staying high.
Thanks, Jane. Anyone else want to come to this question?
I was just going to say, I think, you know, you might not take the pressure off that, you know, that front initial bit of diagnostic, you know, presentation, but if we can diagnose earlier, we're hopefully the objective is to prevent development of, you know, more severe disease, and therefore, you know, and we know that obviously more severe disease is going to place increased pressures on the healthcare system, and, you know, certainly obviously I've been talking about heart failure, you know, readmissions, etc. That's very costly for the healthcare system. So if we can pick up patients earlier, put in a management plan that prevents deterioration, then we will be taking pressure off the system. But, you know, I take your point that I think that initial bit of testing, you know, there's obviously, you're going to need to have the staffing to do that upfront testing. So yeah, it's a bit of a balancing act, I guess.
So I'll come in on that as well. I think it's that population health management approach, isn't it? If you think about where we were with diabetes management 25 years ago, we are there in that same place with a number of other chronic conditions now. So now we manage most diabetes patients in primary care. We keep them stable for as long as possible, and that has reduced the impact on their need for them to be admitted to secondary care, and it also reduces their complications. But we had to double run those systems for a while, and I think that's going to be true for a number of other chronic conditions as we get better at earlier diagnosis and management. I think it's not going to save us money in the short term, but it hopefully will save both patients and money in the longer term.
Thanks, Mandy. And I think we have time for one final question from our audience. So can the panel talk about the use of personal health records for patients to keep pathology results in one shareable single place? Does anyone want to quickly come on this before we wrap up?
Sorry, Daniel, would you mind repeating that for
Yes,
me?
no problem. Can the panel talk about the use of personal health records? So, for example, with NHS login or the app, for patients to keep pathology results in one shareable single place?
I probably can't talk from a position of qualified knowledge, but I can talk from a position of what I'm aware of from what I'm seeing in our programme. And I guess the aspiration is for our pathology services and all the diagnostic tests that we do, where it's clinically actionable, that information is in an electronic patient record. I'm quite sure there's a wider debate about self-testing and other forms of testing about whether that's actually considered a clinically actionable result, and therefore should that end up in a patient record. And I'm sure there'll be a lot of discussion and debate about how a person's own record of their own health through whatever apps develops and how that gets incorporated. I suppose what I can say from our pathology programme perspective is we're trying to do everything we can through the digital investment to support results finding their way through interoperable solutions or directly into electronic patient records, which in theory, and this is where I'm not qualified, will end up in that personal patient record that they can access.
Thanks, Jane, and thanks for your insight. Did anyone else want a 30-second input on this?
I'll quickly come in on this.
Okay.
The one healthcare record, which is being, the patient should be able to access via the NHS app, would have your medical problems and your medication and your blood test results. And from October on, when patients are able to see their forward going patient doctors' entries in their computer systems by the GPs and so forth, would have those entries as well, and along with the results. Now, the question is, would the point of care testing or the self-testing be married into those records? And that is via the virtual wards and various platforms that they have. Do they actually get into GP records? And that depends upon each and every provider, how they get in there. So we know that at the moment, the Libre testing that patients do or blood pressure testing can get into and there are mechanisms of getting them into electronic patient records. So that's something that's another thing that when we explore these pathways further, we'll need to ensure that patients do have access to that, and clinicians, more importantly, have access to that as well, to be able to advise patients better. I'll stop.
Thanks, Mona. And I'm afraid we're almost running out of time, but I would like to invite the panel to share their final reflections before we leave today. It's been a great discussion. So I was wondering if anyone had one 1 minute thing they'd like to say before we head off. Who would like to go first? Jane, can I come to you first?
I suppose my overarching reflection, having been in pathology now for quite some years, is this is really exciting times off the back of the pandemic and all the learning that we gained about the rapid adoption. There really is a level of interest that I've not experienced before. So it's, you know, it really is time to have a call to action for everybody to lean in, understand what has happened, what knowledge exists and how we build on that to make sure we have a better environment of, let's take the lab testing out of the lab a little bit and see what happens to influencing patient care.
Thanks, Jane. And Mona?
I was going to say my take home is that clinical engagement and involving the key stakeholders, including the patients, is really key to this, and making sure that we look at what opportunities there are out there and choosing the most cost-effective options for the patients, not just looking at the cost effectiveness of the test itself, but across the whole pathway. So I think that would be it's exciting times, like Jane said, around using technology to bring care closer to home for the patient and in a more timely fashion, but that just needs to be thought through, processed through, and make sure it's resourced adequately. I'll stop.
Thanks, Mona. And Mandy?
Well, I think it's really exciting as well, the ability to change pathways for the better, both for the patients and for the people who are delivering them. And it provides a great opportunity for all of the staff working across all of the different disciplines. But I think there's more work to do. I think we need to work on that health economics and that evidence base, because I actually think that if we're going to do this, we need to do it properly and not ad hoc, and we don't want to get into a Wild West situation. We need to know that the results are right, that they're accurate as well as appropriate time-wise.
Thanks, Mandy. And finally, Ashton.
Yeah, you know, we're heavily engaged in research in early diagnosis for a range of different conditions, so from oncology to cardiology, metabolic diseases, neurology, and I think there just needs to be a continued focus on this early diagnosis and prevention of diseases. And I think, you know, with a long-term approach to that, it's going to create savings long term. So yeah, that would just be my message.
Thank you. And that's all we have time for today. But I wanted to thank our speakers today. It's been a great discussion, really interesting. A lot of learnings we can take away from the discussion. And I want to thank the audience for your watching and for your questions. We encourage you to share the link to the event with colleagues who can register and watch on demand. And we really value your feedback to help us continually improve our events. So please navigate to the feedback option, which is in the menu on the left, and we will also send out a link to the survey in an email shortly. Finally, thank you again to our event sponsor, which is Roche Diagnostics UK and Ireland. Thank you and have a great day. Goodbye.